Good afternoon, everyone. My name is Dr. Visharat Trivedi. I am working here as an associate professor in cardiovascular anesthesia department in UN Mehta Institute of Cardiology and Research Center since last 10 years. I have been working in post-operative cardiac ICU since last 10 years, and so the topic given to me is management of post-operative cardiac surgical patients. So let's begin the topic. First of all, you should know what are the most common surgeries which are on day-to-day basis doing in our institute or as well as in all other cardiac centers, that are CABGs, valve repairs and replacements. These are the most common surgeries. Other less common surgeries are LV aneurysmectomy, post-MI VSR, repair, pulmonary endarterectomy. All are least common surgeries. Before managing the patient, you have to see what are the factors affecting the management of the patient in post-operative period, like use of CPB during surgery, level of hypothermia, cannulation sites, methods of myocardial preservation which are used during the surgery, level of anticoagulation, and whether they use DHCA during the surgery or not. These all are the factors affecting the post-operative outcome of the patients. In the immediate post-operative care, the most common and most important finding is you have to take a proper history, that in our language it is known as an OVER, which is given to the post-operative anesthetist from the intraoperative anesthetist. So the most important point of histories are patient's background, type of operation, indications for that operation, pre-operative cath report if they have done an angio, success of operation means whether the repair has been successfully done or not, how much regurgitation or anything is left after the repair surgery, CPB time, aortic cross clamp time, ease of separation from CPB without support or with supports, current ionotropes, vasopressors or antihypertensive if it is used, need for cardiac pacing if the patient doesn't have any sinus rhythm or arrhythmias, use of intra-aortic balloon pump or any other ventricular assist devices, whether the patient has significant bleeding, oozing or medical bleeding while after coming off bypass, and other significant comorbidities which patients have, like diabetes, carotid artery disease, COPD, asthma, renal failure, hepatic failure. All have contributions in post-operative outcomes. In addition to that, pre-operative history is also important. You should know that the patient is on some pre-operative medications or not, or the patient has some allergies or not. After taking a thorough history, you should proceed to the examination of the patient once it has come to the ICU under post-operative ICU nurse or post-operative ICU anesthetist. The examination includes the first, you have to assure that the endotracheal tube is in proper position and does not displace while shifting, and patient has equal air entry bilaterally. Remember that the tube displacement and pneumothorax both can occur during the shifting of the patient as well. Verify the patient's oxygen saturation and check the ABG as soon as it is available. Verify correct ventilator settings. Check the initial hemodynamic readings and determine what vasoactive infusions the patient is on. Current vasoactive infusions, current inotrope you should know, and depending on the dosage of the inotropes, what are the hemodynamic parameters the patient have, you should know. Okay. Check the patient's heart's rhythm. Verify pacemaker setting if the patient has some arrhythmias or patient has some kind of block. Check the chest and mediastinal drainage for adequacy of drainage and patency of the test tube. Examine the heart sound, look for any murmurs or clicks if it is a case of valve replacement. Check for all peripheral pulses, especially the dorsalis pedis artery and posterior artery, particularly in case of mini surgeries where the femoral cannulation has been used, or particularly in case of Bental where femoral cannulation has been used. Examine the abdomen for any distension. Examine the pupillary reflexes and do a more complete neurologic examination if patient begins to awaken from the GA. After completing the thorough examination, you should proceed for the lab test. Routine tests which are used in post-operative period is, first and foremost, is ECG. Any new changes you will find on ECG, you should compare it first with the pre-operative ECG. New RBBB is not uncommon, and shift of the axis are also very common and benign changes. However, new STT changes are not benign. Diffuse non-specific changes are not uncommon, but if you find the ST elevation and 2 or more contiguous leads in a territory that was grafted that can indicate acute graft failure. You should notify this to an ICU surgical fellow or a surgeon, and you should suspect that if the patient has a lima, then the lima can go into the spasm, and you should start managing the ST changes right at the start of the ST changes after informing to the surgeon. Arrhythmias, if you find any arrhythmias on the ECG, then try to find the correct cause for arrhythmias. Most common cause is electrolyte imbalance. Try to correct it and start the treatment for any other arrhythmias. The second investigation is chest X-ray. In chest X-ray, you should see the correct position of the AT tube, correct position of Swan-Ganz catheter if the patient has one, correct position of all other tubes and drains, mainly the patency of the drains, and check for pneumothoraxis if it is present during this, if it occurs during the shifting, and check for any collapses or atelectasis. Another investigation routinely performed in postoperative cardiac patients are hemoglobin, coagulation parameters like PTA, PTT, INR, particularly in the valvular cases. Electrolytes like potassium and magnesium. Patients are known to go into a very brisk diuresis after coming off bypass, and that can lead to electrolyte imbalances and arrhythmias like hypokalemia and hypomagnesemia. And so you should go for potassium and magnesium just as the patient comes into the ICU. Glucose is also very important. The class 1A indication of tight glycemic control postoperatively in all the cardiac patients for reducing the morbidity and mortality. Tight control does not mean that it should be below 100. You should maintain the blood glucose level below 200, between 160 to 180 milligram per deciliter. Cardiac markers also you have to send for any untoward elevation of CPK-MB or troponins. After surgery, it is bound to get increased, but the amount of increase is very proportional to the hemodynamic status of the patient and ECG. Next thing you should consider is the warming of the patient. If the patient has a surgery on cardiopulmonary bypass, then cardiopulmonary bypass is usually has an hypothermia of less than 32 degrees centigrade for all the patients, and at the time of coming off bypass rewarming has been done, but there might be a chances that the rewarming is not uniform, and you may see a peripheral coldness or kami extremity in on pump cases. So if it is there, then there will be a redistribution of heat once patient comes into the ICU, and there will be a severe drifting of the temperature towards the lower side. So what it does to the patient is it predisposes to the ventricular dysrhythmias and lowers the ventricular fibrillation threshold. It increases the SVR because of peripheral vasoconstriction. Patient may shiver once if it comes out from the GA, and that will increase the peripheral O2 consumption and as well as increases the peripheral oxygen demand as well. Decreases CO2 production because of low metabolism. Coagulopathy is a very known complications of hypothermia, and patient should be rewarmed as soon as possible with the use of bear hugger, and which blows the warm air over the body surface to warm the patient by convection mechanism. Another most common complication which you can see after surgery is bleeding. There are two types of bleedings. One is a medical bleeding and another is a surgical bleeding. Medical bleeding secondary to the defects in the coagulation cascade, platelets or fibrinogen. Surgical bleeding is because of the secondary to operative trauma, which includes the leaks at the sites of anastomosis or cannulation sites, or bleeding from small mediastinal arteries or veins. Surgical bleeding requires return to an operative room for re-ex and hemostasis. Now, surgical bleeding should be considered in the following cases, like if the patient has a persistent bleeding in the absence of specific anticoagulant defect. There will be a sudden onset of fresh rapid bleeding, especially if associated with the hemodynamic changes like low pressures, height, heart rate, tachycardia, hypotension, and if the surgical bleeding is more than 500 ml in the first post-op hour, if more than 400 ml per hour for 2 hours, 300 ml per hour for 3 hours, and 200 ml per hour for 4 hours, then it is considered to be a surgical bleeding, and you should notify this to a surgical fellow in the ICU as well as the operating surgeon for re-exploration. Medically bleeding is mainly because of the defect in the anticoagulation coagulation factors or fibrinogen or platelets. It can be occur due to a residual heparin effect, because in OT, when the surgery is on pump, then we are maintaining the ACT of more than 400, and after the completion of the surgery we are reversing it with protamine, but occasionally the calculated dose of protamine given is not sufficient to completely reverse the heparin effect. So there might be a residual heparin effect which can cause bleeding after coming into the ICU. One another entity known as heparin rebound phenomena, which can also occur several hours after post-operative period. In that case, you should go for ACT, and if ACT is high, then you should again repeat the protamine. In the platelet defects, you can see both types of defects, qualitative defects as well as quantitative defects. If quantitative defects are there, you should provide platelet rich plasma, that is PC. And if it is qualitative defects, then you can see that defects in patients who are on antiplatelet agents on the preoperative period or in cyanotic congenital heart diseases. Clotting factor deficits can be seen because of and because of it you can see a medical bleeding. Fibrinolysis also is one of the cause for medical bleeding. Now what you can do to treat that medical bleeding is, first and foremost is correct the hypothermia, because it can lead to coagulopathy. Another one is control the blood pressure if it gets elevated, so it will decrease your oozing. Another thing you can do is give protamine if ACT is more than 120 to counter the heparin rebound and residual heparin effects. One more drug which you can use, and conflicting data are on the DDAVP, that is desmopressin 20 microgram intranasally. That will specifically used in case of von Willebrand disease and in case of uremia induced qualitative defects of the platelets. In other studies the advantage is not much profound, but in case of uremia or in von Willebrand disease you can use desmopressin as well. Platelet transfusions, in case of quantitative platelet defects, ideally you should give 5 units of platelet. That will raise the platelets around 25 to 50,000 in patients, and that will resolve your problems of quantitative defects. Fresh frozen plasma can be given in case of coagulation factor deficits. It is given in a dose of 20 ml per kg, and that will lead to at least 50% increase in the coagulation factor level. Cryoprecipitates also used sometimes to replenish the fibrinogen if it is on the lower side, and it contains also a factor of 8. 1 unit of cryoprecipitate contains 20 to 25 ml, and 8 to 10 units of cryoprecipitate usually are given to replenish the fibrinogen. Antifibrinolytic agents like tranexamine, ESA can be given, that will inhibit the conversion of plasminogen to plasmin and thus preventing the activation of fibrinolysis. But before giving it, you should first confirm that there is a fibrinolysis by elevated D dimers and low fibrinogen, because it can have a potential of thrombosis, including acute graft thrombosis, DVT and pulmonary embolism. Another thing you can do to prevent medical bleeding is to raising the head of the bed or increasing the level of the PEEP on the ventilator. That will basically reduce the venous pressure inside the mediastinum, and that will reduce your oozing. RBCs is of utmost importance to maintain the hemoglobin level as well as an oxygen delivery to the tissues, and that will be given if hemoglobin is on the lower side. The choice of therapy should be guided by hematological laboratory tests including CBC, PTA, PTA, fibrinogen, D dimers. Practically speaking, one does not always have the luxury of time with patients bleeding significantly, and one may have to resort to empirical or shotgun therapy. That means if you don't have any time and patient has compromised hemodynamics, then you should go for all-out approach, like you have to order platelets, cryo and FFP in all the patients, and once you get the test, then you have to selectively replenish the factors. While transfusing the RBCs, you should have a predetermined threshold for each and every patient. If the patient is on severe comorbidities with low hemodynamics, with low hemoglobin, then you should go for a target hemoglobin of more than 10. But while the patient is stable, extubated, but still patient has low hemoglobin, then in that patient your target hemoglobin level should be less than 7. So it is depending on the patient's hemodynamical condition and status of the patients, because RBCs also or PCVs also have a very wide amount of adverse drug reactions like transfusion reactions, infection, immunosuppression by PCVs, and other disadvantages like volume overload and hemolytic reactions. Now coming to the hemodynamic management of the patients, if the patient is showing you hypotension and low cardiac output, then you should know that the BP is because of cardiac output and systemic vascular resistance, and cardiac output is equal to heart rate into stroke volume. So you can say that the blood pressure is equal to heart rate into stroke volume into systemic vascular resistance. Now hypotension can be because of all of the three factors: either your heart rate is low, your stroke volume can be low, or your low SVR, that is systemic vascular resistance. So there are numerous causes for hypotension. You should first identify the cause, whether it is because of pump failure, that is low cardiac output, or because of distributive shock, that is because of low SVR, that is circulatory shock. Okay, so how do you approach to a hypotension in postoperative period is look first at the recent hemodynamic parameters, assess the cardiac output or cardiac index. If the patient has PA catheter, you can directly calculate it from the cardiac output or cardiac index. Look at the rhythm of the patient, look at the CVP to assess the preload. Is afterload high or low? Is the contractility is increased or decreased, or is there any tamponade or not? So first you look at the recent hemodynamic parameters, which is obtained from the PA catheter or from the CVP. You can see the recent hemodynamic parameters. Then assess the cardiac output or index. Now it is very simple. If the cardiac output is low and SVR on the higher side, then this hypotension is mainly because of the pump failure. So you should give the patient drug which are increasing the pump function, that is contractility, with low SVR, that is dobutamine. If the cardiac output is on the higher side with low SVR, then it is mainly because of the distributive shock. Then you should give a patient a volume, that is maintain adequate preload with a constrictive agent like noradrenaline. Look at the cardiac rhythm. Absolute or relative bradycardia or tachycardia can lead to decreased cardiac output and should be corrected. One thing important here is a preload. First you look at the CEP, that will assess your preload. Now here the important point is we are measuring actually a preload volume. We are more in line with the volume, and what we are measuring is a pressure basically. So in case of a low compliance of the right ventricle, you can see that the CVP is on the higher side, but still the volume is not up to the mark, the preload is not still satisfied. So in that case you can give, if you feel that the patient is improved with volume boluses, then you can give 250 to 500 ml of bolus of volume, see for a raise of CEP of 3 to 4. And if the patient's output is increased, if patient's blood pressure is increased, then you can go for a further infusion of the volume. If pressure is not increased and CEP goes on to rising, then that means that there is a severe dysfunction, and then you should restrict your volume intake and increase the contractility in place. Okay. If patient has a high afterload secondary to vasoconstriction or secondary to hypothermia, then you should go for a vasodilator therapy. If patient has a decreased cardiac output, you should go for a inotropic agents. The causes for, and simultaneously you should look for the causes of the decreased cardiac output. If there is a graft occlusion or is there with STG changes, graft spasm can be seen like an ST elevation, prolonged CPP time, prolonged cross clamp time can cause decreased contractility, and low preoperative ejection fraction. Patient has already low EF in the preoperative period. Another common cause for low contractility and low BP is tamponade. Now coming to the drugs for contractility, in itself it's a very big topic. We'll just look at the overview of the inotropes. The main inotropes which are used in postoperative cardiac surgery is dobutamine, epinephrine, dopamine. Another drug, all of these three drugs are used mainly through a beta-1 receptor agonistic action. Another inodilator used which is known as milrinone, which has an action through phosphodiesterase inhibitor, which increases the level of cyclic AMP and thus by increasing the contractility as well as causing vasodilatation. Vasopressor mostly used are norepinephrine, phenylephrine and vasopressin. Norepinephrine mostly used through alpha-1 receptors and causing vasoconstriction and maintain the blood pressure, perfusion pressure. Vasopressin mostly used for refractory hypotension or refractory vasoplasia patients in which you have a high cardiac output with low SVR even after full dose of norepinephrine. In that case, vasopressin acts through vasopressin receptors and causing a vasoconstriction. Another most common complication you can see in a postoperative cardiac patient is tamponade. Cardiac tamponade is basically a compression of the heart that impairs ventricular filling and leads to a low cardiac output. The incidence of tamponade is roughly around 3 to 6% generally, and the presentation of tamponade can be variable, and it is basically a diagnosis of suspicion. You have to have a very high suspicion about the development of tamponade in any cardiac surgeries. The typical representation would be like a patient is having a mediastinal drain 50 to 100 ml through 2 to 3 hours, and then again sorry. Then again if the drain stops and blood ceases to come from the drain, then you have to and that is followed by hemodynamic deterioration with tachycardia and declined cardiac output and stroke volume. Then it is known as, then that may be a sign of tamponade, that because of the clotting in the drain itself, there will be a collection of the blood inside the pericardial cavity that will causing a tamponade. Search for any alternate explanations of low cardiac output, and if you don't find any other alternate explanation, then you have to have a very high suspicion of tamponade. Assure the adequacy patency of the sums or drains. This is a very important sign for tamponade, that is, look for equalization of the central pressures. In tamponade, because of the collection of the blood into the pericardial cavity, there will be a diastolic collapse of the right ventricle, and all the pressures, CVP, PCWP and pulmonary artery diastolic pressures are all remains the same because of low compliance of the ventricles. So that is a sign of tamponade. Look for a loss of Y descent on CVP. Low voltages on ECG. Echocardiograms have their own signs of tamponade. Mostly best way to assess the tamponade is through an echocardiography. Transesophageal echography can be used if there is a problem with a window during a transthoracic echocardiography. The only treatment for tamponade is to return the patient to OR, resternotomy and evacuation of the clot with hemostasis of any ongoing bleeding. If a patient with suspected tamponade suddenly deteriorates and develops pulseless electrical activity, then urgent sternotomy should be done in the ICU itself. That will transiently maintain the pressures and perfusion. Now coming to the mechanically assisted devices, the intra-aortic balloon pump, which is most commonly used in cardiac CABG cases to increase the diastolic perfusion pressures, and in case of to maintain the coronary artery perfusion pressures. In itself is a very big topic, but I highlight some of the salient features of IABP. IABP mainly used by inflating during the diastole, and it will augment the diastolic pressure, and that's how it increases the coronary perfusion pressure. So mostly used in coronary artery disease patients after cardiac bypass to increase the coronary perfusion. Augmentation is mainly triggered through two mechanisms, mainly through a ECG and other method is through arterial pressure waveform. Arterial pressure waveform has a diacritic notch which indicates the starts of diastole, and that's the point where the IABP starts inflating, and that's how it augments the blood pressure. Indications for IABP is postoperative cardiogenic shock not responding to medical therapy, acute myocardial ischemia in medically refractory ischemia preoperatively and postoperative myocardial ischemia, acute mitral regurgitation or VSR, bridge to cardiac transplantation. Contraindications are like aortic insufficiency, aortic dissection and severe peripheral vascular diseases. Complications of IABP are leg ischemia. This is the most common complication, so you should keep on maintain regularly. Every 2 hours you should check the peripheral pulse of dorsalis pedis in which the IABP is inserted. Occlusion of a large aortic branch including renal, SMA or subclavian arteries if the positioning of the IABP is not accurate. Acute aortic dissection, hematoma at the insertion site, wound infection, hemolysis, thrombocytopenia can be because of mechanical compression of the platelets and RBCs. Thromboembolism can be seen if there is a clot in IABP and it will migrate further distally into the cerebral circulation. Arrhythmias, most common arrhythmias in post-operative cardiac surgery patients are atrial fibrillation. The drug of choice is beta block, calcium channel blockers like diltiazem and digoxin. If it is not controlled, you can go for amiodarone, bolus with infusion. Second most common arrhythmias post-operatively is PSVT, that is paroxysmal supraventricular tachycardia. Drug of choice is verapamil or adenosine. VT, VF can be seen in some refractory shock cases. Straight away you should go for a shock. In pulsatile VT you should go for a xylocard infusion or xylocard boluses. VPCs can be seen in sometimes if in electrolyte imbalances. You should correct hypokalemia if it is there, and you should give xylocard for multiple VPCs. Intractable arrhythmias are also there. You should go for a directly DC cardio word. This is basically a reference paper which is published in JAMA Neuro in 2017 for perioperative care in cardiac surgical patients, in which they have recommended the various classes of evidences. The class 1, I would highlight here one of the 3 main class 1 indications in postoperative cardiac surgical patients, that is use of tranexine of on-pump cardiac patients. Perioperative glycemic control, that is you should maintain glucose between 160 to 180. And the third most important class 1 indication is avoidance of only opioid based analgesia. You should use multimodal analgesia and opioid sparing analgesia in postoperative cardiac patients just to prevent respiratory depression as well as hemodynamic stability. This is again the same paper with a recommendation of surgical site infection bundle, in which class 1 indication has performed topical intranasal decolonization prior to the surgery, administer antibiotics 30 to 60 minutes prior to the surgery, and clipping in place of shaving is recommended as a class 1 indication to prevent the surgical site infections. Thank you.